My name is Matt Hendrickson. I'll be kind of the host for the webinar tonight. I have the opportunity to work with DIO and with WhiteCap Institute, and it's my pleasure to welcome you all tonight for joining us. This DIO Digest is really kind of an extension of Dr. Riley and Dr. P.K. Clark's brainchild of a webinar series they started doing during the COVID lockdown, so to speak. It was really kind of gained a really rapid and large following for people who wanted to kind of get some CE when they were kind of locked in their homes. With that, I'd like to introduce Dr. Riley Clark. Dr. Clark is a graduate from Case Western with a DMD degree. He also holds a certificate in IV sedation. He's a clinical mentor and lecturer at the WhiteCap Institute and has been for a number of years. In addition to that, he's also adjunct faculty at the University of Utah School of Dentistry. He's got a master in implant prosthetics from the International Congress on Oral Implantologists, and he's also a board certified diplomate with the International Congress of Oral Implantologists. He's a diplomate of implant dentistry with the WhiteCap Academy of Implant Dentistry, and that's kind of just a short list. I could go on and on, but most importantly, I have the pleasure of getting to work with Riley quite a bit directly, and he's just a wonderful person. For those of you who haven't met him, you're going to learn really quickly that you really like him, and he's got a genuine passion of helping other professionals in the industry. So with that, Riley, I'm going to turn it over to you. Let me make you the host. So with that, if you can hear us okay, I'm giving you control.
Great. Thanks, Matt. I really appreciate that. I pay him to say those nice things about me, so I'll make sure that check is in the mail, Matt, and that's perfect. So welcome to DIO Digest. I'm here actually with one of our dental assistants. This is McKenna. She is also very familiar with the DIOnavi system, and her and I in the future are going to tag team some of these webinars. So she might just kind of be a fly in the wall today, but I wanted her to kind of see what this is like, and if she does have anything to share, your job's to share it. Deal? Okay, perfect. So I'm excited for you guys to be here, and we're going to talk about drilling protocols with a specific focus on outcome-based protocols. I'm all about outcomes. I started my short career here at WhiteCap Institute doing implants exclusively. The first couple of thousand implants I did were all freehand. And as you know, freehand, we can have fantastic results, at least in my hands. You can also have results that are not so good. There's just more of a variety, I find, just because it's a little bit less predictable. Since then, a few years ago, I switched to all digital, all guided surgery. The last couple of thousand implants have all been guided, and I've been so impressed with the different outcome that you're able to get with a consistent protocol workflow. And DIO has one of the very best in the market. And that's why I'm here to talk about that and share some of that with you, with the focus being how can we provide the very best outcomes for our patients. That's what it's all about. End of the day, a lot of us can do implant surgery, but can we put the implant where it really belongs to give the patient the best long-term solution? I've participated in the good, bad, and ugly of that, so I get it from all perspectives. And I'm excited to share what I have found to be the most comprehensive, the most contemporary way of putting implants where we want them, and that's with this DIOnavi system. So hopefully that is what you're here for. If you just do a Google search and you type in dental implants, poor outcomes, these are some images that show up. And you know what I love about these images, they're raw, they're real. This is sometimes what implantology can look like. Hopefully not in our hands, but apparently implants can do this sometimes. I don't know the story behind all of these, so I don't want to be judgmental specifically to these, but I do want to emphasize that implants and the implant being in the right position meaning relative to bone, the right position meaning relative to occlusal forces, that is really, really important for the long-term health of these. And that's what the patients are coming to us for. And we have an obligation to do everything we can to get the implant where it belongs. It's a surgical procedure with a prosthetic component that's really important, but our surgery can really mess up the prosthetics, which will ultimately end in the implant having an issue down the road. So I want to talk outcomes. How the heck do we get the implant in the right position? That might sound easy, but this is one of my favorite textbooks. It's from Stuart Fromm. It's called Dental Implant Complications, Etiology, Prevention, and Treatment. I love this book. If you're looking for a good implant book, I'd recommend this one. I obviously have nothing to do with this book other than I'm a fan of its content. But he says this, and this is a recent contemporary book. He says complications related to malposition implants continue to be seen in implant dentistry and are perhaps one of the most common types of implant complications. My practice is just implants. So I have a practice in Oregon, I practice in Utah as well. Every patient, every day, every hour is an implant patient. And I would agree that a lot of issues I see with dental implants, some by my own hand, some by hands of others, are often related to a malposition of the implant. And so I really feel like this hits home. This is a big topic for me and in my mind. When I teach, when I do procedures myself, I'm always worried about doing everything I can to get the implant in the right spot. That is really going to make a huge difference down the road. And so that's kind of what I want to talk about a little bit, is how do we take our ideal treatment plan that we've thoughtfully considered through CT review, through clinical examination, through proper diagnosis of health history and different cofactors around that, and how do we get the same results, meaning an ideal clinical outcome? Now, I'm taking a lesson, and I think dentistry in general, we should take a lesson from the rest of the world and different everyday common things. I've been driving a little bit the last couple of weeks. I was doing some vacationing with the family, and I only survived because I had an app that had a guidance system on it that got me for where I wanted to go in an efficient and a safe manner. And I really think that today, implantology in 2020 is best done with some type of guidance system. I'm going to share with you the guidance system that I find works the very best. There's a lot out there, just like there's a lot of different apps that can help you get from point A to point B. But I think the idea of guidance, of some type of reference to ensure the proper outcome, we arrive at the right destination, the right clinical outcome, is what we should be doing. And I think we see that in a lot of different everyday things. I had to put this picture in. You might say, what does this have to do with implants? Well, I have a curse. Everything I do in life relates to implants, just because it's what I do all day. I was installing a Ring doorbell. You know, the ones you push the button and a video comes up on your phone and you see if Amazon delivered your packages on time or if someone's stealing them. I was installing one of those. And even the Ring install does what I call guided surgery. You hook on this little level, and as you're mounting the bracket to your home, you use that to make sure your angulation is perfect. And me being the implant geek that I am, I thought, oh my gosh, that's guided surgery right there. I'm drilling holes in my house with a guide. And it felt like I was at home in the clinic because that's how I do my surgery, with the guide. So I had to throw that in. I think it's pretty common sense. If we can use a tool, just like this silly Ring doorbell has a tool that helps us get a more ideal outcome, why not embrace that? And that's what we're here to talk about tonight. McKenna, does that sound good?
Sounds great. Love it.
You're in?
I'm in.
Okay, she's in, I'm in. Let's do this thing. We're going to talk specifically today about one of DIOnavi's surgical kits called the Master Kit. This is the kit that you use most common. It's for almost all of the guided surgery cases. It works in conjunction of other kits. This is kind of their main kit. But I want to talk specifically about 2 or 3 unique features to this kit that make it really, really awesome. I'm going to go through that for about 15, 20 minutes. And I got 2 clinical cases I want to show you that I did just this week. I want to show you those as well. So this week, like yesterday and the day before. Okay, so here is the DIOnavi Master Kit. It's a clean, nice looking kit. It's got lots of parts and pieces to it, a little intimidating at first, the first time you look at any of them. Basically what you're seeing is on the left is some piloting initiation drilling. In the middle are a lot of your larger osteotomy prep drills. To the right, you're seeing some of the implant drivers, different profile drills, ratchet connections, things like that. So a lot going on there, but that's the kit. It's a nice, beautiful surgical kit. Let's jump right into what their protocol looks like. And I want to share just a couple of thoughts with their protocol because it's going to play a role on what we talk about next. Their protocol with that kit is somewhat unique. What is unique about it is they do what I call stepwise drilling to length. So if you look at their drill here, and here my little cursor should be on your screen, this number here in this row is the length drill to use. So this is a picture form of what your workflow is going to look like in terms of your drilling sequence. And if you're going to go down, let's say to 10 millimeters, they don't have you just load up the 2x10 and drop it all the way to length. They go down 5 and then 10. And then when they jump up to a wider diameter, they still follow a stepwise approach to length, a 5, an 8.5, and then a 10. That's really, really clever. I'm just skimming over this real quick, and I'll tell you why that's clever in just a second. They also know through CT analysis and Hounsfield units exactly when you should stop drilling for D3 type bone or what drills you should enlarge to for D1, D2 type bone. And so this is a really thoughtful protocol. This is the protocol that DIO recommends with their surgical kit. They have multiple protocols. So this is for a 4.5 by 10. So if you're placing a 4.5 by 10 with DIO, this is how you drill it. They have other protocols, obviously color coded, and they show you the different protocols for different size implants. So a really thoughtful protocol that I want to dive more into right now in terms of how the drills are actually used that creates this what I call extreme accuracy. So here's some of the keys that I have found. Number one, a flat surface for your initial drill. What do I mean by that? You go to drill on bone that has some sort of angle, and I've never seen perfectly flat bone unless I just reduced it perfectly flat. There's always a little bump or ridge or angle. But if you drill into that, I find you get some slippage. And as you slip, you will be in constant fight with your surgical guide because it started to slip. It's like hanging a wall or hanging a picture on the wall. You put that drill on it, you start to drill, it dances around, and then it jumps in some random spot you weren't intending. I find the same thing happens with implants. So that's a big deal, and I'll show you how we accomplish that. Second, a really, 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 really tight fit of the drill to the guide. What I will tell you with guided surgery is there's a lot of systems, a lot of workflows, but they are not all the same. Just because Dr. A is doing guided surgery does not mean that Dr. B, who's doing guided surgery, is getting the same result. Guide is not a guide if you're with different companies. And I'm going to show you some of the differences in that when we talk about the fit of the components. I mentioned this already, but stepwise drilling to length, we call that dual contact drilling, and I'll explain that in a minute. Slow drilling, slow speed creates more accuracy in a guide, in my opinion. The reason for that is there's less force rotationally moving around, and as you hit hard or soft spots, it will not deviate because of all of that rotational momentum, and it will just simply follow course, kind of like a little tugboat. It's going to keep its course without all this wild speed to potentially move because of its momentum. And then obviously a properly fitting guide. So I want to comment on the last one for just a second. I have worked with 7 or 8 different guides, plus 2 or 3 different softwares where I made my own guides. And I have never seen a guide fit like I have with the DIOnavi system. That they almost click into place. I mean, it's really, really impressive. And I've spent a lot of energy and effort trying to understand what makes them work better or not fit as well. And DIO has figured it out. It's a really, really good fitting guide. With that said, let's jump into some of these drilling protocols. This is the bone flattening drill. So after a flap is reflected, after a tissue punch has been done, this is the first drill that we use. And its job is to do just what you see in the picture and just like it's called. It will take a ridge that looks like that. That's pretty dang normal. That's what anatomy looks like. And it will take that and turn it into a flat surface like this. If we don't create a flat surface initially, when we start drilling, it will, like I said, deviate one way just a little bit. And then every other drill is in constant struggle to match the drilling path that the guide is asking for because we drifted just a little bit. And so this bone flattening drill is really, really important. It creates that tabletop, which allows us to be perfectly perpendicular to penetrate the bone in a very accurate fashion. That right there is a really, really neat drill. You're not seeing a lot of people talk about it. I know some people will reduce bone on an edentulous ridge, which is great, but you can't always just reflect a flap, reduce a big ridge. You're going to ruin your papilla support. This is a very, very thoughtful, it's exactly the size of your osteotomy, and it will open it up just flat enough or just enough that it's where your implant's going to be and not take any more osseous architecture out of the way, which could affect your soft tissue contours. So that bone flattening drill, in my opinion, is step one for amazing, amazing outcomes. By setting the stage perfectly flat, the other drills have a good opportunity to go straight into bone. Now, this is probably the biggest difference I find with DIO and their workflow as opposed to other systems. If you're familiar with guided surgery, you know that there are systems with a key, or sometimes called a tube, or sometimes called a handle. That's all the same thing. And there are some systems that are keyless or tubeless or without handle. Those are the two methodologies, and I have always loved each of them for different reasons and hated each of them for different reasons. What DIO does, which is really unique, is they allow you to use the tube type system initially and then switch to a tubeless system, which allows us to enjoy the benefits of both, but ignore or get rid of the downsides that they come with. And so that's a really, really unique feature. I want to talk about these two different drilling methodologies for just a second. So on the left of your screen, you see a tube type system. On the right of your screen, you're seeing a tubeless or a keyless type system. The big difference is this, and it all has to do with the initial drill. When I say initial, I'm talking your 2.0, your pilot drill. Some of you might have a 1.8, a 2.2, a 2.0. I'm saying your initial first end cutting drill in a tube type system has this much support, meaning the drill is paralleled all up this blue line before it ever touches the bone. A tubeless system, the drill typically begins to cut bone as this tube just barely engages the guidance of the actual surgical stent. And because of that, you have, unfortunately, a lot less stability. You can literally start drilling here, here, there, wherever you want. And then once you get in the guide, it kind of shores it up. But you've already lost your accuracy because you're somewhere else at the very crest of the ridge. And so this is a really big difference. To have this much support and guidance to get started as opposed to this makes a really big difference. And as you know, with implantology, the more accurate you begin, the more easy the rest of the case will be. That's what I found. Is that what you found, McKenna?
In watching you guys, yes, absolutely.
Okay, there's your endorsement. So let's talk numbers. What has to happen, though, for this to work properly is a very tight fit. So I want you to imagine this. You have the surgical guide, you have the tube, and then you have the actual drill. Well, they've measured all of this. Between the surgical guide and the tube is 0.01 millimeters of space. That's amazing. Now, it's a little bit of a hassle too. Why? Because you have to have it perfectly aligned for it to go down. And when you try to take the tube out, if you're not pulling exactly up, it's wedged in there because it's such a tight fit. Believe it or not, I've used some implant systems that they make them purposely a little bit loose so they're easy to take in and out. But that defeats the whole purpose. I can now wiggle it any angle and start drilling, and it's not even a tight fit. So the tight fit is really important for this tube concept to even make a difference. So we're talking 0.01 millimeter from guide to tube. And then the tube to the actual drill itself, there is 0.1 millimeter of space. So if you add all that up, do some algebra, you find out that that equates to 0.8 degree potential to be off. Not too shabby. When we compare it to a tube system, check this out. So we're talking less than a degree with a tube type system and up to 3 degrees off on a tubeless system. Now, you might say, does 3 degrees even matter? Well, let's look at the math. If you take a 3 degree on a 9 millimeter implant, so your total length would be about 19 because 10 millimeters equals the guide, 9 millimeters for the implant. So a 9 millimeter implant with a 3 degree possible angle, you could be 1 millimeter off to your target mesiodistal buccal lingual at the apex. 1 millimeter. We live in millimeters. We live in fractions of millimeters. That 1 millimeter could be a very, very big deal. And so that could be a problem. Now you go 5 degrees, that could be 1.5. Or if you increase your length and you're placing a 13 millimeter implant, you're over 2 millimeters off if you're 5 degrees one direction. And so that's a really big deal when we talk about buccal plate being close, adjacent teeth being close. We need to make sure we're very, very accurate. And so the numbers speak for themselves. 3 degrees is actually a lot in our industry. Now, with slow drilling though, I actually do not, I'm moving on to the next point. So that was number 1. Number 1 is a tube system for your initial drill, and then a tubeless system after that, which we'll talk about in just a second. What's the benefit? Accuracy. What's the disadvantage of a tube system? I find ergonomically it's a little bit hard. A lot of people like the tubeless systems because it's just easy ergonomically. We still have that ease after the initial drill, but we realize that the initial drill has to be done with extreme accuracy. Therefore, we will follow the tube system protocol for the initial drill. After that, we jump to a keyless system. But I want to talk for a second about slow drilling. I do 100 RPMs with no water. And by doing that, 2 great things happen. 1, I feel like it's more accurate, certainly more gentle and soft on the bone. Number 2, we're able to harvest bone. And so if there's ever any need for bone grafting, then I can actually, as I come out with the drill, the flutes of the drill will be filled with bone because no water has pushed them out. And with that, I can graft with it. So I love, love slow drilling, but here's how we keep the bone cool. You have 10 seconds to push. So you put the drill through the guide, rest it on bone, push the pedal down, 100 RPMs, and you can push for 10 seconds. And they found through research, I'll show you in just a second, that after 10 seconds, you're not going to heat the bone too hot to the point that you could get bone necrosis. And then we have this really clever little thing DIO came up with, this little needle tip with the markers on it. And this goes down through the surgical guide and irrigates the base of the osteotomy. So that's how the bone is kept cool. You will drill, come out. While you're switching drills to a different one, your assistant can come in and irrigate to cool down the bone. I think it's pretty simple to use, right?
Yep.
Would you have any insight with this at all?
No, it's super, super easy to use. You can't mess it up.
There you have it. So here's what they found. If you're drilling at 1,000 RPMs, after about 2 seconds, you're almost up to 60 degrees Celsius. As we know, we try to stay under 40 degrees Celsius at all times. And so what we found here, at RPMs of 100 or less, you can almost go to 12 seconds before you get above 40 degrees Celsius. Now, obviously, how hard you're pushing, the density of the bone will certainly have an effect on that. So we are saying to be safe, even if you can go to 12 seconds, let's call it 10. In my mind, I'm kind of counting to maybe 6 or 7. If I'm not where I need to be at length, I will come out after 6 or 7 seconds, irrigate, and then use a couple more runs to get all the way down to length. But slow drilling is really, really important. I like to think of the slow drilling as kind of an analogy of like a car on the freeway. If you're going 100 miles an hour down the freeway and you just hit a little bump in the road, that could be game over because of all of that forward momentum. If you're going 2 miles an hour down the road, you hit a little bump, that's going to be a piece of cake to go through without any turbulence, without any deviation of your path. I think the same is true with our implant drills. As we're going very fast, 1,000, 1,500 RPMs, and you hit soft bone, hard bone, that momentum can push you in a little different direction. Whereas if you're going 100 RPMs, it's like that tugboat, it just pushes slow and steady forward, okay? So I'm a real big fan of the slow drilling. I think that's a key component to this protocol for the extreme accuracy I'm talking about. Next point, after you've created your initial osteotomy with your initial 2.0 drill, it then goes up to its wider drills, and this is the stepwise drilling that I was talking about. So you might think, well, I'll just load up a 2.7, push it all the way to 10. That's what I would do in the freehand world. Even some guide systems have you just go straight to length. But what they found is they're missing out on an opportunity to get this extreme accuracy by missing out on this contact or this double contact principle. As you are drilling, the surgical guide will meet the tube and help provide stability. But if you can go down a little bit initially with a shorter drill, your next subsequent drill will have guidance at the apical end of your drill as well as the coronal aspect. Let me show you in some more picture form here. When I drill the 5-0, the only guidance of drilling is really right here. Yes, it is following a 2-0 hole that's already here, but really it is following the trajectory that the guide has shown it. Whereas this drill, the apical end, which is what we worry about drifting a different direction, will be secure by the osteotomy prep of the shorter drill we just used, so on and so forth. So you're getting double contact, apical contact and coronal contact. Really, really important principle. We call that the double contact principle. And by getting that, we get, again, this really, really unique accuracy. And when I talk about unique accuracy, I'm talking about being able to put in a custom abutment and a milled PMMA temporary at the day of surgery and having it fit without any or very little adjustment, because the guide put the implant exactly where it was planned on the computer screen days or weeks before surgery. That's the sort of accuracy I'm talking about here. Not just, yeah, it's in the bone, it looks pretty good, it's better than I could have done freehand. There's that's any guide system probably. And then there's this extreme accuracy that gets you some really unique clinical opportunities, and I'll show you that with our cases coming up in just a second. So, dual contact, really, really important. Let's talk about a couple of cases and go through them and show you kind of the accuracy I'm talking about, let you see the system in action, if you will, okay? So, this was a case I actually did yesterday morning. Sweet patient, she's 25 years old, unfortunately. And unfortunately, most of her teeth have big carious lesions. Obviously, 7 through 10, you see a mess, but those posterior teeth are equally messy. And she's elected to take those out. We're going to try to save a lot of the lowers and work with that, but the uppers are going to be an implant solution. So she was in the office yesterday morning. To get a surgical guide, what we did was took a digital impression of the upper and then took a CT. Those files were then merged. A virtual plan was made. I logged online, looked at the case, modified how I wanted it planned just perfect, and then said, all right, let's do it. The lab made a guide, sent me in a box the case with the surgical guide and the implants, and then a denture was made from our referring dentist that sent this case over. So let me show you a couple more x-rays. You see a bunch of these carious lesions on those second molars, on the premolars. Just a real tough case. It breaks my heart, 25-year-old, to be in a situation like this, but thank goodness there are some other options today. So I want to show you what we did. I had the guide ordered, and this is always a unique thing. What do you do in a case like this? There's a bunch of teeth in there. I want to use a surgical guide. Do we take out all the teeth and then put the guide in? Do we take out the teeth and reflect a flap and mount it on the bone? How do we want to do it? I'll show you my preferred methodology when the anatomy allows it. Is I prefer to get the patient in, take out just the teeth necessary for me to be able to put in my implants. In this particular case, she's going to be getting 4 upper implants with eventual locator abutments and a snap in and out overdenture without a palate. And so that's the treatment plan. My implants are going to be in first molar position and in canine position. She happens to only have 1 premolar, and so that just involved taking out these teeth. So I actually use the anterior teeth and the very posterior teeth to basically help stabilize my guide. And the reason for that is our most accurate surgical guides are always going to be tooth supported. The teeth are very stable. Because they are nice and stable, we can use them before we get rid of them. Why am I making a big deal about that? What I used to do was just take out all the teeth and then try to fit a guide on my fresh extracted arch, which always has a little bit of ambiguity because certainly soft tissue has changed, which was already guessed by the lab where it would even be. And sometimes the bone even changes because of the nature of extractions. And so by doing this, I have a predictable fit of my surgical guide. It's a tooth-supported guide, but it's going to be in a dentulous case here in just a minute. So I'm just using these teeth to get the implants in, and then they're going to come out. Okay, so there's the extractions. Tried to be as atraumatic as we could, sectioning multi-rooted teeth where needed. These premolars were not sectioned, and luckily they came out pretty atraumatically, which is nice. But one thing I like about this case as it relates to the accuracy of a surgical guide is, in my opinion, these are tough areas to get your implant and not have it fall into one of these roots. What do I mean by that? Well, I don't want my implant in the distal buccal root. I also don't want it in the mesiobuccal. I don't want it in the palatal. I want it somewhere in the middle. And that's a hat trick to do. Can it be done freehand? Absolutely. Is it hard? Absolutely. Am I really successful doing it freehand? I bet 50% of the time when I used to freehand those immediates, I was really impressed with my result. And I bet the other 50% of the time I wasn't so impressed. And McKenna will tell me, hey, that didn't look very good. So thank goodness I'm doing guides now and I just get compliments.
Makes my job a lot better.
Yeah, exactly. So this is a tough case to get the implant to where we want and not just fall into one of the roots. I need the implants to be parallel across the arch. That can be tough on the maxilla because we have a flare out laterally. And so I need these implants more up and down, and I need them parallel cross arch. This is a tough case, in my opinion, to do it really, really well. And so thank goodness we have a guide to help us with that. So I'm just going to show you a few simple steps. Again, I just did this yesterday morning, and so I didn't have tons of time to prepare some of these slides. But here you're seeing the surgical guide actually in place. You're seeing some windows in the anterior. These windows help me confirm that the guide is seated properly. You're seeing an anterior support and then also the posterior molars I kept, because I want that anterior posterior support. You don't do that, you'll get some rock in your guide. So it's a very, very stable guide. You see I have 4 implants planned, decent AP spread so that these locators will have good retention for the patient. Like the way that looks. If ever your guide is not seating all the way down, don't proceed with surgery. Don't just think, oh, it's close enough. The guide really needs to fit just right in order to get the result you're looking for. What do I mean by that? I've had sometimes when I wasn't using this system, but when I first started doing guides, they would be off maybe a millimeter. So I would think, okay, well, if the guide's off a millimeter, the implant will only be off a millimeter. I can handle that. It is not the case. If your guide's off a millimeter here, then maybe the angle over here is like 6 degrees different, and then you drill down with a 15 millimeter drill and you're 3 millimeters off. And so I've learned from Sad's experience that do the extra effort to make sure your guide fits perfect before you just start drilling holes. You'll be grateful you did. So you see here my initial drill with the tube in place. So this slides into my surgical guide sleeve, and then this drill slides into there and only lets it go one direction with less than 1 degree of variance. That's awesome. After we've done that, I get to switch to these drills that have a built-in key or tube, if you will, and then the guidance is much easier. My left hand, non-working hand, no longer needs to hold the key. Ergonomically, it's just easier because all I have to worry about is the handpiece. Okay? Then the implant goes in. Now, this particular implant does have a rotational, it's not the implant driver does have a rotational indicator that helps me know that the implant hex is in the exact orientation I need it. If I had lab-made prosthetics already, this case, I do not have lab-made prosthetics. We're just gonna bury the implants, let it heal, and I'll come back later. So the rotation of the implant does not matter. So the implants go in, we bone graft it up, and the patient's a happy patient. We take out the rest of the teeth and give the patient her denture. I did take a post-op CT. Now she was sedated and she had a lot of sedation medicine, and so this CT is pretty dang blurry. However, what I love about these images, this is number 3 implant. Look at this, right at bone level where I want it, maybe a little subcrestal, which I love, right in the center of the ridge, not following the natural contour of the alveolus, which would put it out at a buccal flare, but nice and up and down so that the implant on the other side of the arch can actually parallel it at least a little bit more. right to the floor of the sinus. I love to engage that cortical bone for strength of the sinus. I love everything about this. You see a little bone graft here in one of the buccal roots, but the implant did not fall into that. It went right in between it. So I love that. I would love to take credit for it, but let's be honest, the surgical guide did the hard work for me, and I'm grateful for that. Number 6 implant, you see where the tooth once was, right up here, little bone graft material. My only complaint here, maybe I should have gone even longer and grabbed the floor of the nose. I don't mind doing that. I think for a locator case, this is plenty good. This is an 11.5 length. Subcrestal, plenty of bone on both sides of it. Beautiful. Next implant, this is number 11, plenty of bone on the lingual, tons on the buccal. Number 14, same thing, tons of bone, right barely at the floor of the sinus, so we're grabbing some of that cortical bone. That's what the case looked like. Again, she moved a little during the CT, so it looks a little blurry. But that's a great result, in my opinion. And what I loved about the guide is that's a fantastic outcome with very little clinical stress. Was I worried about the parallelism intraoperatively? Not necessarily. I was worried about it pre-surgery as I was doing the planning on the case. And so was I worried about the buccal plate? Was I worried about the sinus? Well, yes, because I'm a surgeon trying to figure out where it is, but the guide allows me to go into those places or around those places with lots and lots of clinical confidence. And so really, really happy with a result like that. The entire case probably was about an hour and 20 minutes. And the implant part, I don't know, if I had to guess, I bet we were placing the implants for maybe 15 minutes, if that. And so it's really, really efficient. It's really, really accurate. Who would not love that sort of outcome and not have the clinical stress of trying to accomplish that? If I were a patient, this is what I would ask for, is a workflow that gives me this sort of result with minimal clinician input, if you will, meaning it just happens because you followed the guide. Not saying you don't need to be knowledgeable and know how to handle yourself with implant surgery, but it's great if you can have a GPS system navigating your way through the roads of your surgery. Okay, let me show you one more case, and then we'll take it for questions and answers. Does that sound good, McKenna?
I like that.
Are you going to show them this case, or should I do it?
I think you should probably do it. You're the clinician.
Okay, I'll do it. Very good. So anterior, immediate with a fixed temp. I love this. These are like my favorite cases for a guide just because they turn out so beautifully. So patient comes in, number 8, needs to go. So we took the tooth out as atraumatically as we could. We took our time. I was happy with how the periodontium looks after this extraction. Sometimes they look this good. Sometimes it looks like I beat them up a little bit. This one happened to look pretty good. This was done earlier this week as well. So that tooth came out. Strapped my surgical guide on. You see the very nice intimate fit of my surgical guide. That's what all these windows are for, to help you see that. You see the surgical guide in place. Now, I'm going to kind of jump onto a new topic, which is the guide kind of anatomy. Notice these little tabs or wings, one towards the buccal, one towards the palate. Those are going to be very important for this particular case. And the reason for that is I have a lab-made abutment that has to fit the hex rotation of my implant placement. So when I put this implant in, if I don't rotationally stop it at the right time, we call that the timing, then the hex of my abutment will not line up with the hex of my implant. And this is an indicator that lines up with the driver of the implant, and it helps me know that the rotation is all perfect. So I'll show you that in just a second. Maybe right now I'll show you. So we did the surgery, we drilled a little, undersizing the osteotomy so we can ensure primary stability. And then you see this little silver notch. There's actually 3 of them on this driver. One right here, one over there, one over there. So you have 3 opportunities on the driver itself, and then 2 opportunities on the surgical guide. You just need anyone to match up with anyone. So if I missed this one, meaning the implant was at its proper depth, but that's not lining up, hopefully this back corner one is just about there. And it's as easy as just rotating it a little bit more and making sure that one of these silver areas lines up with the tab of the surgical guide. And again, by doing that, we ensure that the timing of the implant is going to match the restoration that was made. So implants in. I ISQ'd it. I like the penguin, a chair side implant stability quotient. This case, my dang flash didn't show the number, but it was about 82, so nice and strong. I always pack a little bit of bone at the buccal gap. A lot of people say if it's less than 2 millimeters, you don't need to. If there's any space between the front of my implant and the buccal plate, and there better be, by the way, there should be on an anterior case, then I always put bone in there. I typically use bovine for that. I like the osteoconductive nature of that, and I just want to maintain space as long as possible, and bovine does a good job of that for me. So after I ensure that it's been grafted properly and the stability is ideal, and for me it has to have an ISQ above 65 and then a torque value of at least 35. And I achieved both of those criteria. And so I had a custom abutment. This was put in at the time of surgery. I designed the margins to be about 1.5 millimeters subgingival, just to make sure that in the surgical phase and the healing phase that we don't expose a margin. And it fit like a glove with the rotational timing just perfect. And then the crown goes on. Now, I don't love the shade. The shade's a problem. However, this is real. This is what happens. Maybe in your offices, your shades are perfect all the time. Mine aren't. However, what I will say, I love the way this fits and fills the space, the way the soft tissue and the fixed temporary are together. That is going to end up being a beautiful final product because we treated the tissues right, we treated them proper. An outcome like that is what this is all about. So I talked about extreme surgical accuracy, and I purposely wanted a case like this. Thankfully, I did one this week and could show you something that just is relevant, meaning it just happened. But something like this is where the extreme accuracy, the little details of the DIOnavi system, the little small details that maybe some people might just say, I don't even think that's a difference. They make all of the difference so that I can do a case like this. I don't remember how long this one took. This was on Monday, but it was certainly under a half hour. Tooth out, implant in, little bone graft, custom abutment, and a PMMA temporary. To do that in 30 minutes, to give a patient that for the reduced stress for me clinically, the reduced chair time to do something like that clinically, that's remarkable. And so I'm really, really happy with that and how that turned out, and really happy that a patient can get something like that, and that there's a protocol and a system that can get us to that destination, because that's really, really exciting for me. My patients are loving services like that. So that's a couple of clinical cases highlighting the accuracy that you can get with a really thoughtful protocol, a thoughtfully designed surgical kit. I hope that was helpful for you. I want to thank you for your time and attention. Guys, I want to appreciate you for your time and for your attention. That's my personal work email down there, Riley@whitecapinstitute.com. I'm always happy to help. I'm a clinician at heart. It's what I do all day, and I'm in the business of helping other people get to what they want to be in terms of their implant practice. So if I can be helpful with anything, don't hesitate to reach out. We will be doing these webinars, I think at least one a month, if not 2 a month, and we'll hit little different topics. I'll try to throw in some cases that I did that week or that month, and just kind of share with you kind of what's going on in terms of what sort of cases am I seeing or doing. So I do see a couple of things. All you need to do is submit your DICOM and your STL file through a specific online portal. After you do that, in 24 to 48 hours, a surgical plan has already been done, and I just log in and look at the screenshots of what it looks like. It probably takes me 2 to 3 minutes for a single implant to review the plan. And then it probably takes 10 to 15 for a large complex case, because all the heavy lifting was done from the lab. And these lab techs that planted are very, very thoughtful. I trained a lot of them, so I'm a little biased, but I think they're very thoughtful with how to plan. And so that is really, really easy. The phase really, it's probably 24 hours if it's busy, 48 hours before some sort of digital plan can be looked at. This will be recorded, and so if you missed some of the beginning part of it, it is recorded, and I'm sure Matt can help us know where they can look at it. Again, I just want to thank you guys for your time. Appreciate your attention. I don't see any other questions coming over, so Matt, I'll probably just turn the time back over to you.
Okay.
Appreciate you.